dear audience, let me introduce my PhD thesis title, which is Infections in Fibrosing Interstitial Lung Disease. My name is Zsombor Zoltán. I work in the Department of Pulmonology in the Semmelweis University, and I am an internal medicine specialist, and my second specialty will be infectology, because I'm interested in infectious diseases. That's why I have a vision that infectology will be an inseparable part of the evaluation of the interstitial lung diseases. I have a team supervised by Veronika Müller, and together we have a mission to provide evidence-based data that draws attention to the importance of infectology. I have two projects ongoing. The first one called Comparing the Effect of Antifibrotic Treatment on the Incidence of Respiratory Tract Infection in Idiopathic Pulmonary Fibrosis. It's a systematic review and a network meta-analysis, and I plan to submit it today. The problem is that IPF is a rare but deadly disease with a median survival of 3 to 5 years. And the best treatment which can be given to the patients are antifibrotic drugs. These are standard of care now, but they can only slow down the progression. And we know that antifibrotics reduce the investigator-reported acute exacerbations and mortality. And behind this high mortality, acute exacerbation is the #1 killer. And acute exacerbation can be triggered by many things like drug toxicity, pollution, but the most important is infection, because we can impact the numbers of infections, and reducing the occurrence of infections by any means is one of the most crucial things in preventing the evaluation of the pathogenesis of chronic lung diseases and preventing acute exacerbation of IPF as well. So we know that antifibrotics reduce the occurrence of acute exacerbations, but we don't know if any antifibrotic reduce the incidence of respiratory tract infections. So our aim is to investigate the effects of different antifibrotic treatments of IPF on the incidence of respiratory tract infections. So our clinical question, is there any antifibrotic drug associated with the reduced incidence of respiratory tract infections in IPF? To answer these questions, we use the PECO framework, and our hypothesis is some antifibrotic treatments are associated with the reduced incidence of respiratory tract infections in IPF. So we conducted a systematic search with this search key, and after the selection, 25 eligible full text remained. Here, let me introduce my results. My outcome parameters are the incidence of the respiratory tract infections, and again, we aim to do this research because reducing the incidence of respiratory tract infections can be the most important thing in preventing the #1 killer acute exacerbations. And the incidence of respiratory tract infections can be very high in IPF. The range stands between 27 to 74% in a 1-year duration. So we included 25 randomized control trials in this research, and we compared drugs intended to treat IPF to placebo. And the high heterogeneity can be seen in the pirfenidone group, where capacity 4 and 6 are outliers because they reported only serious infections. And high heterogeneity can be seen in the antibody group and in the other drugs group because of different mechanism of actions of the drugs. So based on a 52-week treatment period, the currently used antifibrotic drugs were not associated with a lower risk of respiratory tract infections. So to check which one of the currently used antifibrotic drugs is better for the patients, we conducted a network meta-analysis. We included 7 randomized control trials with more than 3,000 patients and almost 1,000 number of events. And based on our results, there was no superiority between the currently used antifibrotics based on their effect on the respiratory tract infections. For overall ranking, we used the random effect model to calculate the p-score for probability, and based on our results, pirfenidone might be better for the patients, but again, our results are statistically not significant. For confidence rating, we use the cinema, and due to a relatively high risk of bias, a high imprecision and incoherence, we gave a very low confidence rating. We conducted subgroup analysis as well regarding dose dependency. We included the same 7 randomized control trials with the same patients. And based on our results, we didn't find any difference between the currently used antifibrotics, between the doses of the currently used antifibrotics. Only in one study reported a significant decrease in the incidence of respiratory tract infections, but it is important to mention that this was a single country study with 1,800 milligrams of pirfenidone per day. So, for overall ranking, we used the same random effect model, and of course, 1,800 milligrams of pirfenidone per day was the best choice for the patients. By the localization of the infections, regarding the localization, we checked upper respiratory tract infections and lower respiratory tract infections, and based on our results, there was no significant difference between the currently used antifibrotics on the impact on the respiratory tract infections. So, of course, we have some strengths and limitations. Our strength is we pulled data only from randomized control trials with high number of patients and events. This is the first network meta-analysis regarding this topic, and it has a clinical significance. And we have some limitations. We have some concerns and high risk of bias. The highest limitation may be that there is no microbiological reports in the articles, and there was no diagnostic methodology reported in these articles. So our conclusion is that the currently used antifibrotics are safe and do not change the incidence of respiratory tract infections without any difference between the two drugs. And our implication for practice that currently used antifibrotic drugs can safely be utilized without risking increased incidence of respiratory tract infections, and our implication for research that further randomized control trials with add-on therapies and real-world studies with respiratory tract infection incidence as a main outcome needed. So my first project is in an advanced stage. I finished writing the manuscript, and I plan to submit it today. My second topic, called Comparing the Effect of Different Immunosuppressive Treatments on the Incidence of Infections in Scleroderma-Related Interstitial Lung Disease. It's also a systematic review and a meta-analysis, and I plan to submit it until November. The problem is that ILD is one of the major forms of lung involvement in patients with systemic sclerosis limiting survival. And the prevalence of ILD approaches 50% of patients with diffuse cutaneous systemic sclerosis. So we know that ILD plays an essential role contributing to the death of patients, and we know that we can decrease the incidence of ILD by treating the patients with immunosuppressants. But this is a risky treatment because they also increase the risk of infections, which also leads to death. So our clinical question, is there any immunosuppressive therapy that associated with a reduced incidence of infections compared to other immunosuppressants? To answer this question, we use a PFO framework, and our hypothesis is some immunosuppressive treatments are associated with a reduced incidence of infections in SSc-ILD. So we conducted and it is very important because if there is a connection, then we can rank the available immunosuppressive treatments based on their effect on treatable traits such as infections. So we conducted a preliminary research, and we conducted a preliminary data extraction table, so we consider our second topic feasible, and I started to register my Prosperum. So to summarize, I have 2 projects ongoing. The first one, planned submission date is today, and the second one is until November. And I want to open the discussion part with the words of Albert Einstein. The important thing is not to stop questioning. Thank you for your attention.
Thank you very much, and congratulations on your both projects, and fingers crossed your paper got accepted.
Thank you
I have
very
a
much.
question regarding your first or the topic. You just, as I understood, you just looked at the incidence of respiratory tract infections, but using antifibrotic therapy, does it change mortality due to respiratory tract infection or progression of the disease due to respiratory tract infections? Do you have any data on this or?
Actually, I don't have any data on this, but antifibrotics reduces the mortality of the disease because they reduce the progression and the fibrosis of the disease. So I believe there is no direct impact on the incidence of respiratory tract infections. Maybe because they reduce the progression of the disease, this will have an indirect impact in reducing the incidence of respiratory tract infections, but our results showed that there is no such effect.
Thank you very much.
Thank you.
Thank you for the presentation. I have a question regarding your first topic. So antifibrotic seems to have a really significant effect on reducing the acute exacerbation, but are there any known side effects of this drug?
Yes, that's a very good question. Actually, there is no superiority between the two drugs. So when we treat the patients, we choose that one which has fewer side effects for individually that patient. For example, pirfenidone, one of the major side effects of pirfenidone is rash and photosensitivity. So if the patient is a gardener, for example, I won't choose pirfenidone because nintedanib doesn't have that side effect. But the most common side effects are gastrointestinal side effects.
Thank you.
Are you aware of the hard endpoints of these randomized controlled trials that are investigating the effects of the antifibrotics? What did they use for the safety measures? What kind of endpoints did these RCTs use for the safety endpoints of using these drugs?
Yeah, almost all the study, the first endpoint was the forced vital capacity decline in 1 year. And the respiratory tract infections were secondary endpoint, and usually they were reported as adverse events.
I see that. And were there any RCT stopped before they planned to do the follow-ups for these patients due to safety endpoints overload?
Yes, there were some randomized control trials, and that's why we decided. That was one of the reasons we decided that we include only those randomized control trials which last at least 1 year. Mm-hmm. This was one of the reasons, and the other reason was that we wanted to exclude seasonal effects. You know, respiratory tract infections has a seasonality, so we wanted to exclude that.
Mm-hmm. I see. Thank you.